Yeah, thank you very much for this interesting topic. I think it is also a very actual topic. Well, it is seen a lot, and we can start directly. So we talked about the statements we do on the CRAFTA education, how we deal with this with neuromusculoskeletal therapy. And the plan for today is that I give an update in Bruxism, then how we assessment this is the assessment tool of STEP, how we examine this and propose for treatment. And so, first, a brief development of Bruxism. First, very good described. The symptoms are described by Sigmund Freud. And Sigmund Freud saw a lot of cramps in the face, especially by women. And he related it with conflicts, emotional conflicts, yeah, more than 100 years ago. And in the time afterwards, a lot of ideas came in from cramp in the face of that it have to do with the catatonia. There's a kind of a neurological disease. Or it has to do with the dystonia. We also now still know this neurological disease like orofacial dystonia. Or trismus, we also know. And also bruxism. So the bruxism part came so more after 1919 and further and later. And but it is already described in early times, so more than 100 years ago, by a dentist. She is called Marie Piekartz. Look, sounds a little bit Polish, but it is a dentist from Paris. And she saw that the rhythmic and sustained tonic connection of the jaw muscles could be a kind of a muscle problem. Yeah, and therefore she called this also bruxism. And if we look to the ethology and we go to the whole process of research, what is mostly done by dentists, yeah, then there was a lot of examination or research naar central mechanism, yeah, the neurotransmitters who are excited and therefore you get a contraction of the muscles. Psychosocial factors, think on the year 60 and 70, we thought that the cramps has to do with psychosocial components, so psychologists were also interested in it, and dentists were focused on occlusion. So you could manipulate the occlusion, and therefore you get a reduction of the tension in the muscles, and that for your cramp, your bruxismus changed. So there are a lot of interventions also the last years, yeah, what you can do, and with and without effect. Medication can have effect, psychological intervention, biofeedback, and also occlusal interference. Um, Now, the dentist groups tried to examine this more in the past, and they also look to prevalence studies. And what we see that the prevalence, yeah, is 5% of our population has a kind of a bruxism, yeah, and bruxism, sleep bruxism, more than awake bruxism. The definition I want to tell you later. Dominantly between 18 and 30 years, and less than by 30, 65 years and older. Dominant by women, and also a very important uh, psychological factor or contributing factor is the social economic status. The more patients have stress on their work, yeah, and how to deal with their daily life, yeah, the more bruxism they saw. Yeah, and a lot of people have no complaints. Manfredini did a publication in 2016 and saw that about a half of the people have no problems. Um, Head is also to do always with pain or headache. In a review from 2022, in this review from Conti et al., they see that there's a relation with awake bruxism and tension headache. That the more bruxism you have, the more chance you get also tension headache. And there was no difference in awake bruxism and migraine. And sleep bruxism is not associated with tension headache. And so that means that there are probably different mechanisms. And that means that also awake bruxism and tension headache are most associated with each other. And I think also when we look to the practice, if you get a patient with a tension headache, you have to diagnose tension headache, bilateral pain in the face, yeah, and you asked the questions about orofacial hyperactivity, like bruxism. And then, in a lot of cases, people you can recognize that they have a kind of a bruxism. The group, the informed group, the International Network of Orofacial Pain, ja, onder de chiefs of commands van Professor Frans Lobiso and Professor Daniel Manfredini, yeah, they did an international consent meetings. Yeah, they did it about more than 8 years. It was a reflection about the signs and symptoms and the assessments, yeah, in the dentist group. And they came to a conclusion. And they did a new definition of what bruxism is. And they reflected also in the STEP. The STEP tool is a standardized tool for assessment of bruxism. So that are from 2018 to 2020 a lot of, let's say, informal and also guidelines stands up by this group. So, and the reflection was we have to reconsider the definition of bruxism and how do we use it, how do we deal with it. In Germany, also the Deutsche Gesellschaft für Funktionsdiagnostik, yeah, that is a group of clinicians who do a lot with functional assessment and treatment of orofacial pain. They did also a deep let's say, a deep research on literature, and then they make the guidelines for Germany. And these are nearly the same as that what the group of Manfredini and Lobiso did. So international, there's now a lot of consensus about the same definitions. And I think also as physical therapist or logopedian or psychologist, we have to know these definitions. And you can download this also on the DGDFDT website. They are very open in it. There's a guideline in English, but also a guideline in German. Then this month, or 1 month ago, not so long, so 1 month ago, 15 April, a new update is coming on the bruxism definitions. The same group had again several meetings, and they rephrase and reflect again the definitions. And also in this lecture, I want to integrate this definition. So I hope I'm very actual and accurate. So what is the definition of bruxism? Bruxism is a repetitive jaw muscle activity characterized by clenching, grinding of the teeth, and or bracing or thrusting of the mandibular. And the four activities I want to explain for 1 minute. Bruxism has two different distinct cardio manifestations. It can occur during sleep or during wakefulness. And they changed the word repetitive and distinct cardinal manifestation. Yeah, so with repetitive is means before they had rhythmic. Repetitive is jaw muscle activity reoccur from time to time, not to a recurrent or activities at regular intervals. Yeah, dus if you have a rhythmic manifestation, you can say, okay, there is a fixed duration, always in the morning from 10 to 12, yeah, and in the evening from 8 to 10. So no, it is now repetitive. So you can choose also or count the frequency, and that can be independent from time, but can depend from, for instance, context. Cardinal manifestation, circadian manifestation. Circadian manifestation is an expression of behavior in relation to the 24-hour sleep-wake cycle. So it is a very fluency mechanism in sleep and in wake. So probably the mechanism goes very slow over in another mechanism. It is not really, um, let's say, black-white. Yeah, so there is an cardigan manifestation. So that has also some consequences also for the four symptoms or behaviors we see by bruxism. That is grinding, clenching, twisting, and bracing. So grinding is you can say the dynamic tooth contact brought about the jaw muscular activity. Grating may or may not be accompanied by sound. So what they changed is also it has not to be always be sound. So you can imagine that you go with a saw over a hard structure, and you hear it by some people, and some people don't do it. And it is a dynamic process of the teeth on each other. Yeah, grinding, yeah, is the statical contact you have. Yeah, so you have an axial pressure on the teeth and therefore an increased muscular activity. So there are two different things. Yeah, the dynamic occlusion by a high pressure with teeth contact, and the clenching is the high statical teeth contact with increase component. And then number three, yeah, all these two, what we see here, were with teeth contact. The, the second two, what's coming now, is all without teeth contact. So bracing is an equivalent of clenching, but now without teeth contact. So you're increasing, yeah, your activity of your muscles, but yeah, there is no teeth contact. Yeah, so holding parts together or in a place, making something rigid or steady. Yeah, you can see this. You see this also by small children. Yeah, when they're in stress or they want to start to cry, you suddenly see an enormous tension on the jaw muscles, but without teeth contract. Here you see an example of bracing. Yeah, you see that there's a higher tension and small movements without teeth contact. Yeah, so this person gets a lot of headache. Yeah, when she is in stress situations, for instance, when she is standing in a traffic jam and she have to be at home, and when she is on her work, when she work behind the computer. Um, so bracing, yeah, is yeah forceful maintaining yeah component from the teeth. Then thrusting, thrusting is the contact equivalent as grinding, but then without teeth contact. Yeah, there are sudden forceful movements, yeah, from the jaw, and you see also mostly facial muscles who are moving, yeah, like this. Yeah, and yeah, this woman had teeth on each other, so you cannot see that she had teeth contact, but yeah, I can promise you that she had no teeth contact. Yeah, it's like a kind of a sucking what you see. And in this patient group, you see mostly also symptoms like that you could look intraoral. They work a lot on her inner cheek, and you see a small flap or a white line where they press on the teeth sometimes. So that are the four main definitions. This without and with teeth contact, and both mechanisms are the same. Then we have to look to the definition of sleep bruxism. Yeah, so they changed the next one. So first the bruxism definition, a masticatory muscle activity during sleep that is characterized as a rhythmic, phasic, and non-rhythmic tonic and is not a movement or sleep disorder. And they changed the word in otherwise healthy individuals. This was a discussion point in this group. Otherwise, healthy refers to healthy persons. Yeah, so it can be that this also has persons who are not healthy. You can have a comorbidity and still can have bruxism, but you can also have no problems and get sleeping bruxism. And awake bruxism is the contact or the activity during the night, during the day, so like bracing and twisting, Yeah, but also here the word otherwise healthy individuals is gone. Right? So it can also be by in pathological sense and in an normal functional sense. So Bruxism, um, from this consensus, is more a behavior than rather a disorder. So in the last progression, yeah, and studies, they reject. They call it was always so that bruxismus was seen, special sleep bruxismus, has to do with your sleeping behavior. Yeah, does the superficial sleep give more activity in your orofacial region, and therefore you sleep more superficial in the morning. Therefore, you have also in the morning more bruxism. That's one hypothesis. Yeah, but there are still more studies who don't confirm this. So therefore, they reflect it and say it is more a behavior than a disorder. So a movement disorder, yeah, is an neurological condition characterized by problems with movement. Yeah. So bruxism is a motor behavior rather than a disorder. And therefore, there can be different components who are associated with each other. So, behavior, why do we have this behavior? So, it can be a risk factor for something. Yeah, dus why shall we assess this and why shall we treat it? For instance, it can be a risk factor. I come later on it. It can also be a protective factor. A lot of people press to get more concentration. We see this in studies by geriatric people that if they have a pressure on the teeth, they can concentrate this more and the activity of their brain is more active. Or neutral. You bruxism, you have bruxism, but you have no problems. You have no pain. You have no signs and symptoms. Yeah, so these are the three factors who can influence it. So bruxismus
Weiß ich gerade nicht. Ich höre da gerade was zu, warte.
is not correlated with risk factors, yeah, but is associated. Yeah, so we see that bruxism can give bad teeth. What you see here, the general health of the teeth change. Or what we know, and that is not by all the people so, you get a mechanical tooth wear and we get an attrition, yeah, what you see on the left side. Or when you have an orthodontics treatment, yeah, or you have a prosthetic treatment, and your teeth are going, yeah, are destructed by higher pressure because you have bruxism. Or, last but not least, yeah, you get a temporomandibular joint dysfunction. The musculatory muscles are so increasing and give therefore pain. And so that means, yeah, bruxism is not a kind of a myofascial TMD. As a lot of people think that bruxismus is a kind of a myofascial temporomandibular joint dysfunction, but it is not. It is a completely different mechanism. But it is a risk factor. Yeah, so what can be a risk factor or associated with bruxism? That can be psychosocial factors. We know of different studies, yeah, that is an increase of stress and an increase of stress hormones come free. It has an influence on the increase on activity of the jaw muscles. Malocclusions can have. Interesting is also the GERD, the gastroesophagus reflux, yeah, who can cause more bruxism. It has to do with the pH from the castor, and then you get a gastritis and therefore an increase of muscle activity. Myofascial dysfunction, yeah, where you get more increase of a muscle activity, yeah, and your sleep awake rhythm. Yeah, if you get less sleep, yeah, or arrhythmic sleep, it can be a risk factor for bruxism. So it is not direct correlated, but associated, and probably you need also a lot of things more. So you can see bruxism is still on the move. It is still so people working on it, reflect on it. The criticism of me is, of course, that this is only a group. This informed group is a group with for dentists. It would be better also to have other disciplines in it. Psychologists, yeah, physical therapists, yeah, experts who also do research and have clinical experience. And what I hear from this group is that they also want to do this in the future. So then, how can we examine this? So there is probably still not a diagnostic tool where you can say, you have bruxism or you have not bruxism. So we need a kind of an assessment tool to investigate this behavior, bruxism, and how to evaluate this. And there are two axes what they also discuss. Yeah, that can be the clinical-based assessments, yeah, an instrument-based assessment, and you can look to the etiology and risk factors. Yeah, so two kind of things, and but that is projected in a kind of a grading system. And grading system will to say how strong is the kind of bruxism here in this particular patient. So I can do three things. Subjective based. So I can ask the patient, do you have grinding? Yeah, my husband becomes awake, yeah, every night, always on 3 o'clock or 5 o'clock. And yes, on my job, I press on my teeth. And is then also, you have also, is this related with headache? Yeah, sometimes afterwards I'm tired, get headache. Then clinical based, so I can do an assessment, orofacial. Can look to the orofacial region. The teeth, is the wear and tear changes? How is the nociceptive input from the myofacial region by this bruxism patient? And instrument-based. Instrument-based can be, for instance, that I do in polysomnography, yeah, or an EMG. And so self-report, then inspection, and instrumental, polysomnography or EMG. Yeah, inspection dominantly and physical tests. So again, as a reflection, bruxism is classified as a behavior, not seen as a disorder or a dysfunction. Not standing alone medical diagnosis. Assessment focused on behavior and modification, not on pathology. 3, and you see here 4, but I could not count when I make this slide, so it is number 3. Grading system can help us to communicate about bruxism in all different disciplines. And there's a very important interdisciplinary consensus is crucial and is often related with dentists, psychologists, physical therapists, logopedians. So how do we examine the patient? So on the CRAFTA education, we bring this information and we go not more in depth also about the mechanism behind it. Yeah, and then we give an overview, how do we just assess? First, subjective assessment. I come later on it. Then appropriate questions. There are some questions you can use for this patient group to get an impression if they have an bruxism. Then examination from the temporomandibular cervical region. Are there contributing factors, dysfunctions from TMJ or cervical who can have influence on the bruxism? I never know. Yeah, that is what we have to do because we see patients for a longer time, 3, 6 weeks. So we can look if the signs and symptoms from the orofacial cervical region is changing, if this also changed the pattern of bruxism. And last but not least, we look to the orofacial somatosensory distortion. So the body distortion somebody has. There's also, of course, the question mark, is this also disturbed by patients with bruxism? So in The questionnaires we advise and we use is the neck disability index, because is there a nociception coming from orofacial region that can also be projected on the neck? I want to discuss that later. The jaw function limitation scale, what is you can download in different languages on the informed DC-TMD questionnaire or website. The Conti questionnaire, I find this a very functional question about if a patient has TMD, yes or no. Yeah, and then the Bruxism status questionnaire. We try to validate at this moment this questionnaire in a research we do on Bruxism. So then some psychosocial cofactors, like the GAD, the general anxiety disorder questionnaire. 7 questions you can ask, and a PHG, pain health questionnaire, who analyze depression and anxiety. And here you see an overview, and you can download these questions. Very simple questions, but also robust because they are also assessed on validity. Yeah, you can do. Yeah, you can use the pain health questionnaire, questionnaire of 4 questions, and the anxiety disorder, and the neck disability. I think everybody knows this questionnaire is used a lot also in research, but also good in clinic. Yeah, and the Conti question you see here, and it's a questionnaire with 10 questionnaires. Yeah, and you see also there's some cutoff points also if a patient had TMD problems, yes or no. This is good to know when I find some signs and symptoms in my temporomandibular joint dysfunction examination, and also the Conti question is positive for instance, mild or moderate TMD. Yeah, that is a confirmation, and I can use it also again for assessment and reassessment. And here we see the joint limitation scale. Yeah, so I have a lot of possibilities to do. The Bruxism status questionnaire is a questionnaire on the background of the literature. You ask questions yes or no, and that are what you see here. See 20 questions. Yeah, they are all related with bruxism from the literature. Yeah, in the study we did in 2019, yeah, we saw that when the patient has more than 12 points, yeah, the chance is very high that there is an bruxism. Yeah, but now I have to say that this study is running now, yeah, about the validation of this questionnaire. Then we look to the inspection. Yeah, open the mouth, look to the lips. Are the lips in tension? Is there an upper lip tension, for instance? Niet an upper lip tension, but an upper lip tension. Niet the neurodynamic test of the arm, but you see by this woman, she is relatively relaxed, but she had an increased tonus, hypertrophy of the right masseter. Yeah, and there's another person right below who have a lot of pressure on the teeth. Therefore, the standing ischemic situations of the pulpa, what you see here, yeah, on the teeth flesh, and what can also give bad health of the teeth. Yeah, and so we have to look to the condition of the teeth. And are there also red flags? So, yeah, in our education, we also talk about red flags in the mouth. So we have to look to red, white areas who are very good circled. Yeah, for instance. Yeah, that can be a big red flag, but it's not the topic at this moment. So the TWIS, what is a very nice clinical examination of the tooth wear evaluation from Peter Wesselhuis. He is a Dutch dentist who's working op de ACTA in Holland, in Amsterdam. Work in the group also with Frank Lobezo. They make a kind of a grading system for the teeth. And what's also easy to use for for not dentists. And we had 2 years ago, we had with Professor Dr. Peter Wesselaar an internal voortbilding or internal course for our CRAFTA assistants and teachers. And it is a very easy kind of assessment to say something about the teeth. Yeah, so and these two articles are supporting this. So when we screen the temporal and the cranial cervical region. Yeah, because this is what we call the orofacial cervical region. This is one unit. And so I can also have cervical problems here. So as you know, you do the examination, mouth opening, physiological movements, you look to the click, the sensitivity of the muscles by algometer, statical test, we can do the accessory movements and the neurodynamic movements. Yeah, Eastern TMG in the axis 1. At the same time, we do also cervical spine examination. We look to the physiological movements, flexion rotation test for occiput C2, the accessory movements for occiput C2, central unilateral transfer movements, the muscle palpation from the deep muscles, dorsally, muscus obliquus inferior, rectus caput inferior, etc., and the mechanical pain pressure threshold, where you go with an algometer and look to the pain threshold. And this cluster of tests give us an information about isthmian dysfunction in the cervical region. We did a study in 2019 where two dentists tried to look to the teeth, and they have to say if they have an bruxism, yes or no. So that were patients from physical therapist and a dentist. Then two dentists look, and we did a self-report of bruxism and neck disability, and the dentist has to distinguish is it a bruxism patient or not. And then we look, for instance, also to the pain projection. And we see that a lot of pain progression by bruxism is more in the temporal and the mandibular area, but also in the neck. So a lot of patients with bruxism have neck pain. Yeah, and you can imagine that, for instance, when the orofacial region is not sensitive, but the projection pain is more in the neck, the patient gets also neck treatment. And if you look to the questionnaire, the neck disability index, we see that there is a significant difference in pain intensity, headache, and sleeping. When you look to the bruxism group and compare with the control group. And if you look to the test of the neck, we see that there is a significant change in pain. Yeah, there's more pain by the bruxism group, but no significant difference between the physiological movements. Yeah, so like rotation or cardinal movements, flexion rotation, the pain threshold, and the pavement. So the pain is changing. You see on the right side in red the pain values, but not in the physiological movements. Yeah, there's not in the impairments. So that is of course interesting that we can conclude that neck pain in bruxism may be projected pain to a trigeminal sensitivity, probably, by the afferent information coming from the chewing muscles into the nucleus caudalis, rather than through iatrogenic and myogenic cervical dysfunction. And that is what very important for us, that we see that this pain probably is false positive for cervical tests. Okay, can it be associated? So we now, the last 4 or 5 years, we look also to the somatosensory distortion. To explain what it is, I have here the patient Fleur. She was a real patient for me, but I smirked her a little with AE. You see that. So she is 20 years old, sleeping disturbance, more 7 years. She has a tension headache, bilateral tension headache, and she had jaw muscle activity, tension more left more than right. So she said, yeah, when I do an analyze, says my perception is that my size, shape, and proportion of my face is changed. So on the left side, you see how she is. On the left side. On the right side, you see how she feel herself. She says, I feel that my forehead is smaller on the normally. She said also a kind of a feeling like I have a hamster cheeks. Yeah, but if you look, you don't see it. But she have the feeling. When I have my headache on the left side, yeah, then I feel also a swallowing on this side. Yeah, so she had the feeling of a swallowing. And if you look to her subjective sensitive skill, yeah, and I ask her, what is, where do you feel the best? Yeah? Where do you feel, sorry, yeah, where do you have different sensations? Then, yeah, she feels on the right side everything very intense, yeah, and on the left side not, especially in her lower quadrant left. Yeah, so that is a patient who have dominantly bruxism with also myofascial pain. So if you look to the left-right recognition and to the emotion recognition, we see that left-right recognition is very optimal, but she is rather a little bit slower. And she had also here some difference in emotion recognition, but not too much. Yeah, especially in sadness. But the time is a little bit slower than normally. So yeah, these are the reference values. Yeah, so she had 3.2 in emotion recognition. Reference value is 2.4. And so she had probably also a somatosensory distortion. So when we do this as an examination, then we have to ask, is there a clear bruxism? Yes or no? Is there a clear TMJ? Yes or no? And can it be comorbid with bruxism? How far is there a trigeminal sensitivity? Yeah, do I reduce nociception from the ventral part, the orofacial region in relation also with the neck? Yeah, and is there an orofacial somatosensory distortion? So in this case, we can use for management strategies. And at this moment, the advice from the DGFDT, the German group, but also from the informed group, is that if necessary, the dentist can look to the occlusion, but the correlation with occlusion is minor. You can use pharmacological approaches, but this is very extreme, of course, because it is a long time and when there's also extreme problems. Psychological behavior approaches or musculoskeletal physical therapy approaches. So we can also be useful for this group. So the proposal is to do manual therapy, look to the signs and symptoms where they have them and treat them, do a reassessment, and look also if the rhythm of bruxism is changing. Individual coaching, awareness, from the bruxism and bruxism neuroeducation. Yeah, and if it exists and stays and the quality of life is still not increasing, maybe consent with dentist, psychologist. Dus orofacial manual therapy. Yeah, we can think here on trigger point treatment, what you see here. Yeah, or trigger point treatment with small passive movements to stretch the muscle. Yeah, mostly with a little bit pain, but during the mobilization it becomes better. Or here, the pterygal medial muscle, where you palpate on the medial side and you do a lateral torsion with movement. The movement of the trigger point together with stretch techniques from the muscle is mostly less painful if you trigger only in trigger point. Then individual behavior techniques like for instance, tongue-teeth breathing exercises we learn, the habitual reversal technique, where you learn in the context to relax the muscle, and the bracing reflex technique. Now, also 3 weeks ago, a new app is online. That is the Brux app 2.0. Yeah, and this is a new app. Yeah, you can download. It costs now a little bit, but you can use it, and did analyze your behavior. So you get push-ups, messages, and you have to say what you are doing. Yeah, and on the background of the Brux app, there you can say that you have a bruxismus, yes or no, and that is new. And you can also change your behavior. Look what we say. It is more a behavior problem than a movement disorder. So we can use also this Brux app. Pain neuroscience education or Bruxism neuroscience education. Trigeminal sensitivity, you have to explain. Influence van contextfactors, or the control van systematic movement and exercise. That is very important. Very important, in my opinion, is that we break down the daily rhythm, so that you get also this rhythm of when Bruxism is coming up and not. Yeah, so that you have to break down, and that you have to explain. Yeah, and this is an example how you explained it. For instance, you have your deadlines. Now, use the word deadlines not, because deadline is very, dead, it's very negative, om so to say. Say that you say, okay, supporting lines or received lines. Yeah, and explain how the motor mechanism work. So you need a little bit knowledge about how it works, in the periphery part and how it works in the brain. Okay, so it's a long known that cognitive training, can reduce tension of the muscles, but also tension of pain or reduction of pain. And we did also in a study a few years ago, where we combine orofacial manual therapy and neuroscience education. And we saw that by this group, with chronic bruxism, the patient becomes better. Yeah, so they have still a bruxism, but quality of life is better. So again, at the end, the recognized bruxism is a behavior pattern. It's not a medical disorder. Screen for musculoskeletal associated dysfunction that we have to do. Educate about the nature of the bruxism. It's very important. Most people want also to know what they have. Integrate physiotherapeutic treatment. This orofacial manual therapy. But try to prove if it is relevant or not. If it is not relevant, don't use it. Refer or collaborate with other professionals. Let the dentist see if the abrasia can be a possibility related with bruxism. As you know, also, if you get a splint, in early times, there still are dentists who are in favor for a splint to reduce the bruxism. But in several studies, in reviews and effect studies, you see that there is no significant outcome for a splint. And therefore, primarily we use it for protection of the teeth. Okay, so you find the assessment and management of bruxism on the CRAFTA website. Because of this new elements what comes in from the informed group, we did not actualize this at this moment, but that will be in 1 month.